This is Dr. Dirk Elston. I'll be walking you through the normal anatomy of the skin. The surface keratinized stratum corneum is a series of polygonal plates that connect in two dimensions. The reedy ridges viewed from the undersurface resemble an egg crate, but in two dimensions form an undulating pattern. This is a carve out of the epidermis. The pattern is quite regular in normal skin, but in pathologic processes often forms irregular acanthosis as pictured above. The individual keratinocytes start at the stratum basale and progress upward into the stratum spinosum, the granular layer, stratum lucidum on areas like the palm, and then the stratum corneum. In greater magnification, we see melanocytes as light blue within the basal layer, the basal keratinocytes in dark blue, the spinous layer above in pink, with Langerhans cells dendritic embedded as a darker red cell in this case. The granular layer is a darker red layer at the top, the stratum lucidum above that, and then the stratum corneum. Going from the top down, stratum corneum, stratum lucidum, found generally on the palms and soles, but also present in pathologic conditions like lichen simplex chronicus. The granular layer, the spinous layer characterized by cell-cell junctions which become most evident in spongiotic processes when they're stretched apart, and the basal layer. Within the basal layer, the melanocytes sit and connect on average with about 10 keratinocytes. Underneath the epidermis is the dermis, and then under that the subcutaneous tissue. The dermis is composed of collagen and consists of an upper, very loose papillary dermis and then a denser, bundled reticular dermis. The papillary dermis is noted extending into the reedy ridge pattern, and below that the coarser bundles of the reticular dermis. Antigen-presenting dendritic cells, both a 13A positive population and a CD34 population, are noted within the dermis. Higher power, we see the papillary dermal collagen as much looser, and then below that the coarser reticular dermal collagen, and embedded within that the dendritic cells. From top down, papillary dermis, reticular dermis with the dendritic cells embedded. Below that would be the subcutaneous tissue. Subcutaneous layer is composed of lipocytes divided by septi with the blood vessels present within the septal structures. So higher power shows the septi in between the lobules of lipocytes. The lobules of fat, when necrotic, are typical for a lobular paniculitis, whereas entities such as erythema nodosum that are septal paniculitis, not surprisingly, are localized to the septum. Below the subcutaneous fat is a layer of striated muscle, especially on areas such as the head and neck where Smaz muscle is visible. The basic components of the epidermis will be discussed next. We have the overall schematic of the epidermis. The keratinocytes start as columnar basal cells which form a palisade at the bottom, the spinous layer, granular, and the keratinocyte. Melanocytes are present at the basal layer and, as noted before, tend to communicate with about 10 keratinocytes in a unit. Langerhans cells are dendritic cells that are CD1A positive and function in the afferent limb of the immune response. Merkel cells present in the basal layer are slow-reacting touch receptors. They're often associated with follicular units and, of course, give rise to Merkel cell carcinoma. The next topic for discussion is the extracellular matrix in the dermis. The extracellular matrix is between the coarse collagen bundles and, of course, the area where the dendritic cells reside. Fibroblasts are present, which, without special stains, are difficult to distinguish from the immune antigen-presenting population. They become much easier to distinguish with immunostaining for factor 13A and CD34. The fibroblasts themselves tend not to be dendritic, whereas the truly dendritic population are the antigen-presenting cells. Elastic fibers form a network that extend into the papillary dermis. Disruption in the elastic fibers would be typical of entities such as a scar and scarring alopecia. Elastic fibers are also displaced by melanoma, and that staining can be very helpful in distinguishing nevus from melanoma. Within the papillary dermis, the elastic fibers have a vertical orientation. In the reticular dermis, they have more of a horizontal orientation, although they form a three-dimensional network that in two-dimensional cuts appears somewhat fragmented. Collagen is present both within the papillary and reticular dermis, and in the reticular dermis, the bundles generally appear much thicker than noted in this schematic. The next topic for discussion are the skin appendages. This is overall schematic of the skin, and we'll dissect out each item and discuss it individually. The eccrine sweat gland has a lower coil, a straight segment of the duct, and then a curled, coiled intraepidermal acrosyringium. The coil of the secretory unit sits often surrounded by fatty tissue within the deep dermis. The apocrine sweat gland is associated with the pilosebaceous unit. Apocrine sweat is more visible and is fairly brightly eosinophilic, often noted within the lumens, not seen on this particular schematic. When not visible, it looks like this schematic where you have very large soap bubble-like lumens. The sebaceous gland viewed in 2 dimensions looks like it comes off one side of the hair follicle. In 3 dimensions, it actually surrounds the hair follicle about 270 degrees around the follicle in a skirt-like fashion. The individual cells of the sebaceous gland are characterized by multiple small lipid vacuoles that scallop the central nucleus. The erector pili muscle extends from one side of the follicle, and in 3 dimensions is really a series of muscles that tether to various areas and then all converge on the same bulge region of the hair follicle. The hair unit itself will be discussed next. The follicle is noted centrally surrounded by a follicular sheath. The hair bulb is the lowest portion where the germinative epithelium resides. We'll look at the structure of the hair. We'll discuss the individual components of the hair follicle next. The hair follicle extends from the epidermis through the dermis into the subcutaneous tissue in most cases. An anagen hair is composed of 4 parts. The infundibulum is the uppermost portion from the surface to about the level of the insertion of the sebaceous gland duct. The isthmus is located below that from the sebaceous gland duct entry down to the level of the attachment of the erector pili muscle. The stem begins below the bulge region where the erector pili inserts and extends down to Adamson's fringe. And then the bulb region extends from Adamson's fringe down to the base of the hair follicle. We'll look at the structures in cross-section next. In cross-section, there are several layers of the hair follicle, and we'll dissect each of those out. Within the center is the hair itself, consisting of a central medulla, outer cortex, and then the cuticle. The hair medulla in the center is in red and often breaks down to form air spaces. The hair cortex is composed of harder keratin and does not form air spaces in normal hair. And then the outer cuticle is composed again of a hard keratin that interdigitates with the cuticle of the inner root sheath, and that's what anchors your hairs in place. The inner root sheath is composed of 3 layers. The inner root sheath cuticle is the innermost layer. Next is the Huxley cuticle, which is the last to keratinize, and so usually easily visible because of the bright red trichohyalin granules within it. Surrounding that is the Henle layer, easy to remember because they make the hen live outside the barn, so the Henle layer is on the outside. Surrounding that is the outer root sheath, which is in the lower segment of the hair follicle, composed of glycogenated cells, so very easy to identify. Surrounding that is a glassy, eosinophilic, vitreous basement membrane zone. And following that, the fibrous root sheath, or fibrous hair sheath, which is composed of fine collagen bundles and concentric fibroblasts. Next is discussion of the cellular adhesion structures that keep our skin together. Desmosomes are the cell-cell junctions and form visible connections in H&E sections, in fact give rise to the spiny appearance of the spinous layer. Ultrastructurally, you have attachment plaques and fibrils. The intercellular space is where the 2 structures connect. And then there's the portion within the keratinocyte. The plasma membrane divides those portions of the structures. The cytoplasmic dense plaque is found immediately below that cell membrane. And the keratin intermediate filaments act as anchoring fibrils that connect to that dense plaque. The desmosomal structure that is visible in H&E sections is the attached area between the 2 plaques. The molecular structure of the desmosome is quite complex. I'll give you a moment to review the writing on the slide. I won't read it all to you, but the most important antigens here are the cadherins, which are desmoglians, glue for the desmosome, and also the desmocollins. The desmoglians 1 and 3 are important, being involved in pemphigus foliaceus and pemphigus vulgaris. The next is the discussion of the dermal epidermal junction. The DE junction is located below the basal layer and above the dermal connective tissue. We'll dissect out that part and take a closer look. Here's a schematic or cartoon of the various structures, and we'll go step by step through each one. The basal keratinocyte sits above the basement membrane zone, and various of the components actually are intracellular components. Below that is the lamina lucida. Below that, the lamina densa, visible as obviously a dense line in electron microscopy. And then the components within the sublamina densa region. These become especially important in immunobolus disease because we define the diseases and know then how to treat the patients and what the prognosis will be based on where the immunoreactants deposit. First, we'll focus on the components within the basal keratinocyte. The keratin intermediate filaments are located above and really throughout the cell structure. Then there's the inner hemidesmosomal plaque. The hemidesmosomal attachment plaque. The plasma membrane of the basilar keratinocyte. Below that, the lamina lucida. The subbasal dense plaque. Bullous pemphigoid antigen 1 is an intracellular component. That's the BP230 antigen. Plectin is located in a similar location. BP antigen 2 is the key antigen in pemphigoid and is actually a transmembrane antigen located both within the cell and within the lamina lucida. The alpha-6 beta-4 integrin also spans that same zone. Some people pronounce it integrin. I think you'll hear it both ways. CD151 antigen is also located, but predominantly towards the cellular side. Next are the components within the lamina densa. Laminin 5 is important in antiepiligrin pemphigoid. Laminin 6, Nitogen, Perlecan is also known as basement membrane zone specific heparan sulfate proteoglycan core protein. And then the sublamina densa region where again we'll see more antigens key in immunobolus disease. The anchoring fibrils are key area focus of antibody for both bullous lupus and for epidermolysis bullosa acquisita. The anchoring plaque includes the type 4 collagen. And then the anchoring fibrils, which are type 7 collagen. The type 7 collagen is the key antigen for both EBA and lupus. Next is a discussion of the circulation. There is a subepidermal plexus parallel to the surface, perforators, and then a deep plexus present at the junction of the dermis and subcutaneous tissue. We'll dissect out each of those portions and look at it individually. The arterial supply comes into the skin and forms part of the deep plexus at the level of the dermal subcutaneous junction. Venous drainage is parallel to the arterial side. Papillary loops are present within the papillary dermis. The subpapillary plexus is the location of the postcapillary venial, which would be the site for most leukocytoclastic vasculitis. The intervening cutaneous plexus is composed of perforating vessels and is really sort of a no man's land in terms of discussion of superficial or superficial and deep infiltrates. Both can involve the perforators, and so when we talk about superficial, we really talk about the superficial plexus, the postcapillary venial, and superficial and deep as being both that level and the vessels at the dermal subcutaneous junction. The arterial side of the cutaneous plexus contains shunting structures and is frequently the focus of inflammation. Again, though, the key points are the zone above that, the postcapillary venial, and the deep vessels, the deep plexus present at the junction of the dermis and subcutaneous fat. And those will all be discussed within this app as we go through the inflammatory dermatoses and the algorithms that will be useful to you in establishing the diagnosis. We hope you enjoy it.